Hi, I'm Dr. Michael Brisman. I'm a neurosurgeon from Long Island. I'm part of a neurosurgery group called NSPC Brain and Spine Surgery. And I wanted to just update you on the topic of acoustic neuromas. Acoustic neuroma is a type of benign tumor that arises from one of the cranial nerves, the nerves that supplies things in the head, the eighth cranial nerve. And the eighth cranial nerve has functions of hearing and balance, and the acoustic neuroma is a benign tumor that arises from the balance part of the nerve, the vestibular part of the nerve. So some people call these tumors vestibular schwannomas. These tumors are benign and are slow growing, but they can grow at different speeds. They can grow and then stop growing. Some patients have small tumors that never do much of anything, and sometimes the tumors can become very, very large. They're almost always just on one side of the head. In rare cases, people can have them on both sides of the head, and this is associated with a genetic disorder called neurofibromatosis type 2 or NF2, but that's very rare. So most of the time, this occurs in adults and occurs on one side. People will usually present with eighth nerve problems. So the eighth nerve could include issues like decreased hearing, muffled hearing, a little dizziness, feeling a little off balance, a little ringing in the ear, things like that. And the study of choice to assess for the acoustic neuroma is going to be an MRI of the brain with gadolinium, the intravenous contrast material. The tumors, again, grow at variable rates, and if the tumor gets big enough, could ultimately start to press on the brain and press on other cranial nerves. So people could end up with facial numbness, facial pain, balance problems. Even if the tumor is really big, could cause buildup of fluid within the brain, something called hydrocephalus. So the ways we can treat an acoustic neuroma are really three ways, three things we could do with it as far as procedures go. Option one is we can do an operation and remove it. And there are different philosophies on this, and I'm going to give you my philosophy because I'm very risk averse, and I do all the treatments, and I think that minimizing the risk to the patient is always the priority. So I believe that surgery is really something that we should do when the tumor is very big. I mean, very big, like, certainly over 3 centimeters, maybe 3.5, 4 centimeters or bigger. Basically, if we have no choice. And again, that determination should be made by, an expert like myself. Also keep in mind that the size is a three-dimensional size, so something that's 3 by 2 by 1 centimeter, is certainly likely to be amenable to something besides surgery. But surgery, I think, is for very, very big tumors and rarely needed. Option two is a focused radiation treatment with machine such as Gamma Knife, which is an outpatient treatment where people come in, they get a helmet on their head, they get a new MRI, they go in this super focused radiation machine for an hour or so, then they go home. Sometimes if the tumor is bigger, we may end up doing the treatment over 5 sessions rather than 1. That treatment, in my opinion, is the way to go for most tumors. Then the last option for acoustic neuromas is just not to do anything and just to observe it, just to get follow-up imaging. If the tumor has been stable for many years, if the patient's older, that may make sense. There have been some recent studies that suggest that people who have the superfocused radiation do better than the people who are just watched. But that said, I think if the tumor is certainly if the tumor is under 5 millimeters, I always leave it alone if it's very small. And if let's say the person already has no hearing and has no eighth nerve function or very poor function, again, one might watch it if it's been known to be stable for a long time. So usually I'm going to recommend the super focused radiation. I think watching, observation alone is going to be a second choice and reasonable, certainly in some cases. And the surgery, I think, again, for very, very big tumors, and when I do the surgery, and when a lot of people are doing it now, we're really debulking the tumor. We're not concerned with getting every drop, because taking every drop of a giant tumor is likely to lead to injuries like to the facial nerve and cause facial weakness or other injury. Whereas if we take out a good part of it, we can then do focused radiation on the remainder without subjecting the critical nerves and arteries and brainstem to risk of peeling a large tumor off those structures. The focused radiation usually will preserve the hearing at the level that people go into the procedure. So if someone has a certain amount of hearing, there's usually about a 60 to 70% chance that that level will be preserved. There's maybe a 30 to 40% chance that the hearing will deteriorate over time and maybe go away completely. People could ask, well, is there a risk to the radiation of causing another benign or malignant or cancerous tumor down the road? And the answer is yes, it's not zero. We are exposed to radiation all the time. You walk outside in the sunlight, there's a risk of getting skin cancer. You get a chest x-ray or a CAT scan. So there is a risk. I mean, it's very, very low, could be 1 in 1,000 or less. I mean, so there's a tiny risk that many years down the road, someone who gets the superfocused radiation could develop some other kind of tumor that could be malignant. But it's a very, very tiny risk, and the risk of succumbing to such disease is much, much, much less than the risk of a major catastrophe or death from the open surgery, which is, at least 1% or 1 in 100. So again, in summary, I think good news with acoustic neuroma is these are benign. Good news is we now have this amazing superfocused radiation treatment that can usually treat these outpatient with minimal risk. You go home the same day, and usually that cures the problem. The tumor either stabilizes or shrinks. Sometimes for the first few months or year, it can swell a bit from the treatment, and surgery is rarely needed, but when it is needed, we can usually do it in a much safer way where we just debulk, take out some of the tumor, and then do the focused radiation for the remainder. So a lot of good news, I think, for acoustic neuroma patients. I've treated hundreds of such patients with excellent, excellent results. And again, I think the key to the results is choosing the low-risk, superfocused radiation, radiosurgery, stereotactic radiosurgery over the much more invasive craniotomy or formal brain operation in almost all the cases. Thank you.